Hello again, my student. Today we are going to talk about the benign prostatic hyperplasia. The benign prostatic hyperplasia is the most common benign tumor in men. The histologic diagnosis is characterized by proliferation of epithelial and stromal elements of a prostate. Incidence is age-related. At 20 among men aged 41 to 50 year of old, the 50% among men aged 51 to 60 years, while the 90% and above in men aged more than 80 years. The benign prostatic hyperplasia develops in a transition zone of prostate. In this picture, we have shown the transition zone. Clinical anatomy. Normal weight of prostate range from 20 to 25 grams. According to McNeil, which is one of the interested scientists in the science of urology, gland is divided into three zones. The three zones are peripheral zone, which is consists of 70% of gland. The central zone, which is consists of 25% of gland, while the transition zone, which have affected in benign prostatic hyperplasia, have the percentage of 5% of gland. The transition zone is periurethral zone of the prostate. And that's the cause after while the urine have been getting not emptying from the bladder. The capsules of prostate. We have two capsules of the prostate. The first one is a true capsule. The true capsule is formed by condensation of peripheral part of a gland, fibromuscular, and is continuous with stroma of gland, while the false capsule lies outside the true capsule, derived from endopelvic vesica. The prostatic venous plexus is embedded in between two capsules. This picture in the end of the slide has shown the arterial supply to the prostate is primarily from the inferior vesical artery, which originates, as shown, from the anterior division of the internal iliac artery. While the venous drainage, the veins from a rich plexus around the sides and the base of the prostate. The plexus communicate with the vesical plexus and with the internal pudendal vein, which drains into vesical and internal iliac veins. Valves communicates exist between the prostatic and vertebral venous plexus, through which prostatic carcinomas spread to vertebral column and skull. When we are going to talking about the etiology of benign prostatic hyperplasia, we have to know that the gland enlargement occurs due to epithelial and stromal proliferation, or impaired pre-programmed cell death, apoptosis, or both, Prostatic enlargement depends on potent androgen dihydrotestosterone, which is called DHT. In prostate type 2, 5 alpha reductase metabolizes circulating the testosterone to dihydrotestosterone, which acts locally. Dihydrotestosterone binds to androgen receptors to cell nuclei. There observed a positive correlation between level of free testosterone, estrogen, and volume of prostate, which suggests that the association between between aging and benign prostatic hyperplasia might result from increased estrogen levels causing induction of androgen receptors, which thereby sensitize the prostate to free testosterone. In men younger than 60 years may be a heritable form of disease. In such cases, it is of autosomal dominant pattern of inheritance. In first-degree male relatives, relative risk is the approximately fourfold. The pathophysiology of benign prostatic hyperplasia. The benign prostatic hyperplasia virtually always occurs in the inner transitional zone, as we mentioned, of the prostate. The affected prostate is enlarged, typically weighing between 60 and 100 grams, and contains many well circumscribed nodules that bulge from the cut surface. The nodules, as the picture shown, may appear solid or contain cystic spaces. That well-defined nodules compress the urethra into slit-like lumen. The urethra is usually compressed by the hyperplastic nodules, often to a narrow slit. In some cases, hyperplastic granular and stromal elements lying just under the epithelium of the proximal prostatic urethra may project into the bladder lumen as a pedunculated or nucleated mass. That mass is called the obstructive of the urethra. These pictures are microscopical pictures, shows the histological nodules we are talking about. The pathophysiology. The symptoms of benign prostatic hyperplasia are related to two causes. The first one is obstructive component of the prostate, while the second is secondary response of the bladder to the outlet resistance. The obstructive, or the first one, which is obstructive, is also divided into mechanical or dynamic. The mechanical one, as the prostate enlarged, the surrounding capsule prevents it from radially expanding, potentially resulting in urethral compression, obstruction, induced bladder dysfunction, contributes significantly of lower urinary tract symptoms. The dynamic component of prostatic obstruction is explained as follows. The prostatic stroma, composed of smooth muscles and collagen, enriched in adrenergic nerve supply, the level of autonomic stimulation sets a tone to the prostatic urethra. Use of alpha blocker therapy decrease the stone and resulting in decrease the outlet resistance. While the secondary response of the bladder to the increased outlet resistance, the bladder outlet obstruction leads to the trousers muscle hypertrophy and hyperplasia as well as collagen deposition. This leads to the decrease in bladder compliance. The trousers instability is also a factor. On a gross inspection, thickened trousers muscle bundles are seen as a trabeculation on cystoscopic examination. If left unchecked, muscular herniation between the trousers muscle bundles ensures causing diverticular formation, and this diverticular is causing the obstruction of urethra. The symptoms of benign prostatic hyperplasia can be divided into irritative, compliance, and obstructive. The obstructive one is hesitancy, decreased force and caliber of stream, sensation of incomplete bladder emptying, double voiding, straining to urinate, post voiding dribbling, while the irritative one is urgency, frequency, and nocturia. Special attention to the following features is essential in making the correct diagnosis and recommending treatment choices. Onset and duration of symptoms, general health issues including sexual history, fitness for any possible surgical interventions, severity of symptoms and how they are affecting quality of life, the medications we are prescribed to our patient with benign prostatic hyperplasia, and the previously attempted treatments. Now we are going to talking about the grading of benign prostatic hyperplasia. The AUA, the American Urological Association, developed a self-administered questionnaire. This questionnaire also have a score, and these scores are called International Prostate Symptom Score, which according to those scores we are going to put the patient in the grade either mild or moderate or severe. The International Prostate Symptoms Scores is gonna to be from 0 to 35. From 0 to 7 the grade is mild. From 8 to 90 to the 19 is the grade is moderate, while from 20 to 35 the grade is severe. This questionnaire, this picture shows the questionnaire which is developed from AUA for International Prostate Symptoms Score, and according to these scores we are calculate from 0 to 35. Now we are going to talk about the signs of benign prostatic hyperplasia. A vesical examination or digital rectal examination are performed on all patients to detect the signs. The size and consistency of the prostate is noted even though prostate size, as determined by DRE, does not correlate with severity of symptoms or degree of obstruction. Benign prostatic hyperplasia usually results in a smooth, firm, elastic enlargement of the prostate. Those pictures shows the grades of that's some type of grading of benign prostatic hyperplasia. In grade 1, the approximately it weight 20 gram, flat or slightly rounded surface. When we are going to take the digital rectal exam, of course. The median sulcus, usually unnoted, with the approximately 1 fingertip length anterior-posteriorly and 1 fingertip mediolaterally. The picture B shows the grade between 1 and 2. The prostate approximately weight 30 gram. Surface of the prostate between grade 1 and grade 2. The grade 1 approximately 40, the grade 3 or grade 2 in the picture C. Its weight approximately 40 gram. By lobar around surface, the median sulcus is well delimited, which is a sign of getting the prostate enlarged. The picture D shows the grade between 2 and 3, where the prostate are weighed approximately 50 gram, rounded surface, partial or obliteration of the median sulcus. So we are seeing that the median sulcus is the one of the most significant sign of being the prostate is enlarged. The picture E shows the grade 3, where the prostate are approximately weighed at 60 gram, rounded surface, complete obliteration of the median sulcus. And the picture F is a grade 4, where the prostate approximately weighed an 80 gram or greater, rounded surface and complete obliteration of the median sulcus also, with no accessibility of the upper limit of the prostate to the tip of the examining finger. Now we are going to end the part 1 of this lecture. We are going to see you in the part 2. Thank you.